Right, I think that's a great question. At the University of Aberdeen, we're always looking for new partners to collaborate and promote our research. This is both to expand our horizons and increase our reach. So we are absolutely delighted and think it's a great privilege to be a part of European Horizon 2020 project in women's health, because women's health is at the forefront of our research agenda at the moment. So I think it was a great opportunity and very, very timely. So again, I think it's a very interesting question. And this is something we are constantly thinking about in University of Aberdeen. We have a commitment to be inclusive, be international, but at the same time be interdisciplinary and sustainable. So to strengthen the human capital, we do it by engaging with stakeholders, we build partnerships, we try and attract the best talents. We value diversity because we know that brings in a lot of new ideas within the university. And since COVID, the world has changed quite a lot. So we have invested both in our virtual and physical spaces where we can allow or enable interdisciplinary exchange beyond the physical boundaries. So I think we are doing everything possible to attract people into University of Aberdeen. We know that we are remote. So actually digital resources are great in engaging across the world. So that's how we are approaching it. Right, so in University of Aberdeen, we have a vision called Aberdeen 2040, which is about being open to all and dedicated in the pursuit of truth in service of others. And we realize that this is only possible if we communicate effectively. So like all universities, we are governed by a research ethics framework. This requires our research to be both transparent and accessible. By transparent, we mean that it can be reproducible. So whatever we've done, if somebody does it again, they get the same kind of results, provided it's the same methods they use. And for accessibility, it is a requirement that all our research outputs, that includes publications or conference proceedings, they are made publicly available within 3 months of being accepting for publication. So anyone can log in into University of Aberdeen website and have a look at that. Apart from this, we also have interactive sessions. So we have several podcast series. One of them is called Cafe Connect, where researchers talk, it's a podcast where different researchers talk about their work. And it's not just about health and medicine. We also talk about a lot of, arts, engineering. There's a lot of work that goes in renewable energy in Aberdeen. So it's not exclusive just to medicine, but nutrition and other things are also there. There are other podcast series like Breaking the Ice Ceiling, where one of our leading researchers connect with women who are striving to drive change, so influential women who are trying to promote change and make this world a better place. So basically, this, and apart from this, we have social media, Twitter feeds, we have several institutes, research centers, each of them will tweet about their own research. And I'll talk a little bit more in detail about these research centers when we come to other questions. But this is how we aid diffusion of knowledge by having an open culture and engage with public. We also have a dedicated PPI unit, which most universities in the UK would have. So we realize that research is only useful if its impact is there in the society. So we do this through collaboration, through dissemination of our research, and working with stakeholders to influence policies. And we've got several examples. So some of them in women's health were single embryo transfer in IVF. This is now a policy. Previously, there used to be 2 embryo transfers, but then there were problems associated with multiple births. So we did research showing that the success rate is not decreased and the outcomes of pregnancy are better. One of the more interesting one, the public health one, was that in the University of Aberdeen, we used evidence which led to the legislation of banning public smoking in terms of health of the society, health of the bar workers, reduced childhood asthma. So this was all about doing with passive smoking, but it was the research and the evidence which we were able to create that the government was forced to make this into a legislation. So we do a lot of translation work, and we have some strong units. We have a unit what we call as PERU, or Public Engagement with Research. We also collaborate with NHS, which is our hospitals and Grampian Public Involvement Network. So people can have the opportunity to engage in research or give direction to our research, and also to come with us with the questions which are most important to them. So this is how actually we try to improve the uptake in the society. And there are many more examples. I mean, there's about, I think we communicated through social media and through formal and informal events. We've done a lot of work lately with COVID vaccination, and we're working on renewable energy sources, nutrition, Alzheimer's. So it's interdisciplinary. And all of this is then, we engage stakeholders to influence policies, and that's how we promote uptake. So innovation is the key for research and development, and we do it through several strands. We promote diversity. We are interdisciplinary because a problem is not usually localized to one discipline. The arms and legs of a problem, and you want to approach it from all ends. We try and attract the best talent, and we seek every possible opportunity. So this is how we actually try and generate innovation-based growth. So what we've done is we have institutes, and within institutes, we have developed research centers, which comprises of experts in that particular area. So we have Aberdeen Centre of Women's Health Research. I'm a part of it. It is a global leader in women's health research. We focus on endometriosis, menstrual health problems, reproductive medicine. Basically, it's a life course approach, right from pre-pregnancy, pregnancy, problems from puberty to menopause and beyond. And that is our aim in Aberdeen Centre of Women's Health Research. Apart from this, we have Health Economics Research Unit, which helps us evaluate cost effectiveness of various treatments and policies, because NHS is publicly funded. If something is not cost effective, even if it's very clinically effective, it may not be necessarily rolled out to general public. We have Health Services Research Unit, which the main areas they focus on is evidence synthesis and clinical trials. We are a very big center for gynecology clinical trials. Apart from this, we have Center for Healthcare Education, Research and Innovation, to name a few. That's looking at more innovative ways of teaching and applying how innovation can be applied in education itself. We have Cancer Center, Diabetes and Cardiovascular Center, Center of Health Data Science, which is based on big data, artificial intelligence. And these are just a few. There are others about nutrition and other disciplines, which I'm not going to go into. So each center is leading the way forward in its area. Because the way sometimes data are extracted, we have to make that distinction between men and women. So I said, it is a turn of phrase, but we are at all times inclusive. So when we use the term women with endometriosis, we're not just talking about women, we're talking about anyone who can have endometriosis, no matter how they identify themselves. So I think this is a very important one, and University of Aberdeen is fully committed to equality, diversity, and inclusion. And we're not just talking of gender equality, it is about all protected characteristics. So that includes disability, or any other protected characteristics that people may perceive. And the reason we do this is we appreciate that an inclusive environment and diversity brings new perspectives, it improves the work culture, and actually it improves outputs of the university. Because if it's only like the same kind of people, you only have the same ideas, you don't get a broader view. So diversity is very, very important. And since last few years, it is actually embedded into everything that the university does, right from recruitment, in terms of our staff experiences, our students, whether you're visiting, the way we advertise things, we try and make sure that it is gender neutral. So it is about equality, and it doesn't hurt anyone's feelings. So we are always very, very aware of it. And the last thing I wanted to say, that it's a part of a strategic plan, which I told it's Aberdeen 2040 strategy, and it is embedded into a strategic plan in every aspect of the work that university undertakes. Probably we were an obvious choice for two main reasons. One, we are leading researchers in women's health across the globe, and in the UK, especially in endometriosis, menstrual problems, reproductive medicine. I alluded to some of them before. We have produced high impact papers. The second aspect is we actually have the expertise and huge experience working with very large data sets. We, in the UK, both in Scotland and England, we have high quality, routinely collected data for millions of patients, which can help us understand the natural course of a condition, such as endometriosis, and also evaluate its long-term impact. My own PhD was looking at long-term health outcomes of women with endometriosis, where I was exploring pregnancy outcomes, impact on cancer, and need for future surgery. So we're very well placed to do the kind of research, or the research question that FEMaLe was asking us to do. We have a very good infrastructure of support. So we have health economics unit, we have a clinical trials unit with experts which can help us evaluate both the clinical effectiveness and cost effectiveness of any intervention. We are doing that kind of research with endometriosis, though not as a part of FEMaLe, but this is also ongoing endometriosis research, which is led by University of Aberdeen. So I think we just tick the right boxes to be a part of FEMaLe. So we are University of Aberdeen, in collaboration with Edinburgh. We are involved in work package 3, which is about clinical phenotype of women with endometriosis. So what we are actually doing is we are assessing the prevalence and distribution of both endometriosis-like symptoms, as well as laparoscopically confirmed endometriosis. We realize that there will be a huge population who has symptoms, but not all of them will actually have endometriosis. So we would be evaluating the prevalence. We actually are looking at nearly 30 years worth of data. So we would also be able to inform how prevalence or incidence of endometriosis is changing over time. And it's not necessarily that the disease incidence is increasing or decreasing, but it may be more due to increased awareness, people seeking healthcare more often, advances in technology like laparoscopy. And given the expertise we have, so prediction models is another thing which we do very well in University of Aberdeen. What we're trying to do is develop a prediction model to aid earlier diagnosis of endometriosis. We would be using data on symptoms and other characteristics of those with endometriosis, such as age, whether they had pregnancies or not, what kind of prescriptions were usually prescribed. We may have some data on, their weight, BMI, smoking, and things. So you'll try and bring all that together to help identify or make a prediction model of who could have endometriosis. This is not just to aid earlier diagnosis, but also to reduce indiscriminate use of laparoscopy. Because at the moment, laparoscopy remains the gold standard. It is, after all, a surgery, an invasive procedure, and not without risks. So it should be used judiciously in people who actually need it. We don't want to just do it in everyone. The 50% of laparoscopies are negative. And as I alluded earlier, we have these fantastic data sets with millions of records. So we know that endometriosis scores can be intercepted by many lifestyle factors, such as if people get pregnant or the contraception they choose, or other lifestyle choices like exercise. So we might be able to explore how these factors affect the natural course of endometriosis. And this data will be very useful in advising women going forward in the future. There are more things we can do. We can look at burden on healthcare, so number of healthcare contacts they're having, prescriptions they're needing. We can use cost effectiveness data, and we can get health economics involved to actually calculate the healthcare burden posed by endometriosis. So these are the things we are doing as a part of FEMaLe. Well, I think it was a success right from the word go. So being a part of that proposal and of this project is a big thing in itself. And it aligns very well with our research priorities, which is about reducing delay in diagnosis with endometriosis, timely treatment options. It covers a lot of things in endometriosis, which we were interested to research. And it has allowed us to foster collaborations, which we are constantly looking at, which means there'll be more opportunities for future. So it's a great start. Obviously, the outputs are not there, but they will come over time. But we are heading in the right direction. So as you rightly said, I have alluded to it. It is collaboration with multiple partners and also for future projects. So the work doesn't end with FEMaLe. This is just the beginning. And through FEMaLe, we are actually hoping to have some very high quality, high impact research outputs, which will have a potential to improve care for those with endometriosis. It will improve awareness. And I think that could be a game changer in itself and new beginning for endometriosis. Endometriosis has lots of problems and lots of challenges, but for me, it has always been lack of awareness. And I think a lot of the problems stem from there. Lack of awareness is a key problem in delayed diagnosis. So first, women don't know when to seek help. So there's normalization of menstrual pain in the culture. So there's a delay from women going to their GP, then or the healthcare professional. Then there is lack of awareness amongst healthcare professionals who do not suspect endometriosis. So there's a lot of time wasted again trying different kinds of treatments or different kinds of diagnosis, such as they may have irritable bowel syndrome. And then there's further lack of awareness, not just about diagnosis, but also how best to manage the condition. And that goes on and on into secondary care as well, once people are referred. And for any particular condition, you can only address the issues associated with it if you're aware of those issues. So we definitely need to improve education and awareness about endometriosis. There are other issues. I mean, it's a very enigmatic condition. We don't understand why it develops in some women or even some men. So it can, we don't understand the pathophysiology behind it. We don't have a way of reliably diagnosing it without laparoscopy, a keyhole surgery, and we don't have a cure. We don't have treatments that work in the long term. The disease keeps coming back. So there are challenges after challenges. I will call it one very long journey for women with endometriosis or those with endometriosis. So one journey is up to the time of diagnosis, where they go through ups and downs, but it just doesn't end there. There's another journey from diagnosis because of recurrent pain, needing to go to healthcare professionals again and again. Our medical and surgical treatment options do not cure the condition. So I think being long-term, lack of awareness, these are the key challenges from my perspective. And the other is obviously lack of funding in research, but that will also come with awareness. So I think that's where we need to start. So as you said, whenever there are problems, there are opportunities, right? So I think in Scotland, for us, the main opportunity or gain point, if you would like to call it, is government's interest. So Scottish government is committed to improve both clinical care and research into endometriosis. They have actually formed short life working groups, advisory boards, and I'm a part of it as well, advising government policies, and there are campaigns going around to increase awareness, encouraging open talk, like period talk. So it's not a taboo. People can seek help when they need to, and also asking for help, knowing where to go for help. So providing more resources, information, support. This is, I think, government's interest and women's health plan in Scotland is one of the key or the fundamental things that would change the scenario for endometriosis. So I think it is now widely recognized that women's health has been underfunded for a very long time, and same for the research. And it's important to realize that women's health has a direct bearing to the health of the society. So it is in government's best interests to look after women's health. So there are several areas, to be fair, I could talk about, but there are three things which I would like to prioritize if I were a prime minister or a politician. So I think the key for me is health education. It should be embedded right from the start. So menstrual education in schools, so that people know what's the difference between normal and abnormal, and open culture in workplaces, but also education of health professionals. So it should be a part of your generic teaching as well, and not just for specialists. So that, and that will improve awareness. So I think awareness is high on my agenda. With conditions that affect quality of life, such as endometriosis or menstrual problems, priorities of women can change over time, and it affects each one differently. So it is about designing and delivering a patient-centered approach and having a personalized medicine. So that is another area I would like to prioritize, because no one treatment or model fits everyone. And lastly, most importantly, funding for women's health problems. And that just does not include problems exclusive to women, but also to reduce inequalities in healthcare that has been faced by women. So for example, if a woman goes with heart attack, the treatment they can get is different from when a man attends with heart attack, because of the perceptions, the biases. So I think I want a level playing field. I want these inequalities to be reduced, and more funding into research, because the same disease can behave differently in women and men. And it's important to understand those differences. That again centers around personalized medicine and patient-centered care. I think that's my three priorities. I can go on and on, but let's stop there.